Well then, okay. Well, thank you very much for asking me to present at NYU Winthrop Grand Rounds. Here's the conflict of interest slide. All my slides will be available free open access after my presentation. And I do have references for the claims that I will be making in the presentation. So they won't necessarily always be embedded and you won't see the references in the slides, but I have references for those. And I'm going to try to make it interactive with asking questions. And so if people could answer those questions in the comment or chat section over on the right-hand side of this talk, then we can make it a little bit more interactive because I know online learning, it's different. My email will be listed on the last slide. And if you have any questions after my presentation, I'm happy to answer them. Please reach out to me at any time. I enjoy that kind of interaction. So I'm going to start with the title slide, and it's from evidence-based medicine, that's what EBM is, to humanist-based medicine, or HBM, gender equity in the House of Medicine. And I really like this picture for nostalgic reasons. It's a historic painting of a setting of an older male doctor that you can see bending over, making a house call, thinking about a sick child. If you look to the top right, you can see a mother and father quite concerned in the background. On the left, you can see a cup of tea and a bottle of some kind of elixir on the table on the left. How the world has changed. I mean, now we can do house calls. They're just virtual house calls. The doctor can be any age, gender, shape, color, etc. And I think we have lots of medicines now that have more evidence behind them than some ubiquitous bottle of elixir. And we've also defined family. That's changed. It may not be two parents. It may not be a male and female. It may be non-binary. It may be a single parent. Who knows? The family unit has changed as well. I thank you for the kind introduction about me. You gave some of my professional status and what I've been doing for the last 25 years in medicine. But I think that since I've been asked to speak on this subject, I needed to provide a little bit more information. And so I am a 53-year-old, middle-aged. I assume that's middle-aged because age and who's old and who's young is always what you are. So if you're 53, 35 is young, but if you're 30, 35 is old. It's all relative. So I'm a middle-aged, white, heterosexual, cisgender, male, atheist nerd. Why the hell am I giving this talk on gender equity in the House of Medicine? I mean, that's crazy, right? Shouldn't it be a female or non-binary person of color and or faith? Well, the reason was expressed quite eloquently by Sir Patrick Stewart. And I hope people recognize who Patrick Stewart is. He was Captain Jean-Luc Picard, or Johnny Luck Pickard from Star Trek. And he's also Professor X from the X-Men movies. And he's also a famous Shakespearean actor as well. And he said, quote, "People won't listen to you or take you seriously unless you're an old white man. And since I'm an old white man, I'm going to use that to help people who need it." Thank you very much for the invitation. I don't know if I should be insulted, but now I guess I'm considered an old white man. I could have used another quote, and this is the first interactive portion. And the other quote I could have used was, "With great power comes great responsibility." Who said that? And be specific in the chat. I want to see those answers. All right, so I was asked to give 3 learning objectives. I gave 5 because that's my favorite number, and anybody who follows the SGEM knows that. So they cut it down to 3. Thank you. So here are the 3 objectives mashed up a bit together. I want to define evidence-based medicine and discuss some of the limitations and possible alternatives to evidence-based medicine. The second objective is show me the money, right? I'm going to talk about gender inequity, and that's one of the ways we can quantify it by using that dollar figure. And I'll use the 3 pillars of evidence-based medicine to focus on those inequities and then drill down into some specific numbers with regards to dollars and cents. And then the third thing, and I was a little bit anxious about including fake news, but I wanted to debunk some of the myths about gender pay gap. And the biggest myth out there is that it doesn't exist. So here's another famous quote. Ready to put your answer in the chat group. The first one who gets the correct answer, I will send them a cool skeptical prize. Here's the quote. It's true. All of it. If you know where that came from, put it in the chat. Now, I teach residents and they don't get my jokes from the 1980s anymore. And so when they start their 1 month community elective rotation with me, I give them a USB key with 5 80s movies that I consider core content for the rotation. It's part of the wellness initiative. And they are expected to watch all 5 movies during their 1 month rural elective. I will be happy to tell people what those 5 core content movies are if you want, but it does change because the 80s has such a huge canon of wonderful movies that I actually target the 5 movies to the learner after my first shift, recognizing which jokes they didn't get. All right, let's talk about evidence-based medicine. There's Dave Sackett, another old white man. He's passed away, unfortunately, but Dr. Sackett defined evidence-based medicine back before some of you were probably born. He said it's the conscientious, explicit, and judicious use of current best evidence in making, and I added the yellow word there, shared decision-making about care of individual patients. And each word is really important to evidence-based medicine. We need to be conscientious, about our decisions. We need to be precise. We need to be very explicit and state what we're doing. We need to use our judgment still, and we need to look for the best evidence, not just evidence that confirms our biases, and encourage shared decision with our patients. Find out what they value, what they prefer, and it's about individual patients. We treat an N of 1, unless, of course, you're in public health now, and now you're treating a whole population. So here's the Venn diagram that represents EBM definition. There's a red circle, a blue circle, and a green circle, and I'm going to use those circles throughout the talk. So the literature is in blue, and it should inform your care. It should guide your care, but it's not a wagging your finger and dictating your care, as in, thou shalt do this. The clinician is in green. Green's the color of medicine, actually. And you need to use your good clinical judgment and apply the literature. And there in the red, the patients. You need to ask them what they value and what they prefer. And there's an easy way to do it. There's an easy way to find out what patients prefer and value. I'm just spitballing here. Ask them. All right, and here's a modified version of the EBM diagram, adds a little bit more context. Many people make the mistake of thinking EBM is all about that blue circle, the scientific literature. It's not true. We need to know the literature, and it informs our care, but it doesn't dictate our care. We still need to use our clinical judgment, and sometimes we'll have vast experiences and like, yeah, I've seen thousands of those. And other times it's like we'll have very limited experience. And then it should start with patient care and end with patient care, and you need to engage them. I often say to patients, I might be an expert at medicine, but you're an expert at you. So between the two of us, we can find the best way to move forward and come up with a good treatment plan. And we all want patients to get the best care based on the best evidence. So those are the 3 pillars that make up evidence-based medicine: the literature, our judgment, and patients' values and preferences. There are various levels to evidence, and this is a hierarchy that's been established, and we want to use the best evidence to care for our patients. And it's usually described in a pyramid, but I like this pyramid, these asymmetrical rocks stacked up. The lowest form is expert opinion. Typically, I say, well, Ken told me to do that way. That's eminence-based medicine, expert opinion. It doesn't mean it's not a form of evidence-based medicine, but we should try to use the highest level of evidence. The middle, the green there, is RCTs. Everybody goes, oh, look, a double-blinded randomized placebo-controlled trial. Wow, we've reached the pinnacle of evidence-based medicine in the literature. No, that's only midway up the pyramid. And the highest is considered a systematic review and meta-analysis there at the top. Now, is anybody picking up on the color scheme I picked out for the levels of evidence? If so, put it in the comment section. And if you remember your grade, your 8th grade science class, it's Roy G. Biv. Red, orange, yellow, green, blue, indigo, violet. But what significance does that spectrum of color have to do with this talk? All right, and there is one higher level of evidence, and that is a randomized, double-blinded, placebo-controlled crossover trial with an N of 1, because we don't treat people as a population. We treat them one at a time. And so an N of 1 would be the highest, although impractical way of doing a research study. But systematic reviews and meta-analyses are put on the top, but we have to watch out for this phenomenon: garbage in, garbage out, GIGO. It means if you take a bunch of crappy little studies, mash them all up into a meat grinder, and spit out a point estimate down to the 5th decimal place and give some impressive p-value, and I don't like peeing all over my research, but give some kind of impressive p-value, it gives you an illusion of certainty when certainty does not exist. To illustrate, I grew up on an apple farm. I'm a rural doctor. I grew up on a farm, and I've been practicing rural for my entire career. And I guess I should define rural. The community I serve in has 4,000 residents. We have a 5-bed emerge that we expanded about 12 years ago by adding 1 chair, so we could improve throughput. That's our blue zone, our fast track. And the only CAT scan I can get has 4 legs. I've been practicing medicine without a CT scanner. Oh. Anyways, my mom makes the best apple pies. That's a hill I'm going to die on. There are very few hills I'm going to die on. My mom's apple pie is one of them. Pineapple on pizza is another, but that's another talk. But that's a hill I'm going to die on. And this is because she used the best ingredients: wonderful apples that were crisp and tart, unrefined sugar, cinnamon, and she baked it with the most valuable ingredient, love. Now, if you take all the ingredients and make a wonderful apple pie, and you add something in a rural area we call a cow pie, and to explain that to your New York audience, a cow pie is something that comes out the back end of a cow. It lands on the ground and goes, and it's about the size of a pie. So we call them cow pies. Well, if you add that to an apple pie, it does not make the apple pie taste any better. All you get is a poop emoji. And so you've got to be careful about the ingredients. I would take a really well done randomized control trial with excellent ingredients over a systematic review full of unblinded or observational studies, trying to get to some bizarre conclusion that isn't supported by the quality of the evidence. There has to be some arguments against evidence-based medicine, and there are some limitations. So I'm going to run through how many? Waiting for my biggest fan to show. I can see what's my favorite number. Show me, people. Let's see it. 5. All right, number 1, harm. We can't do research on harm. In other words, we can't do research where we're going to put people where we know they have an increased risk of harm, not a net benefit. There's not equipoise. Second thing is most research findings are false. The third thing is I don't want to practice cookbook medicine. Isn't that what evidence-based medicine is? Just tell me a recipe and I'll follow it. Why don't you just get the computer, make the EHR even better? Well, not better, but even, like, why do you need me? And then the fourth is good evidence is ignored. So that's talk to the hand. And the fifth one is I'm just so busy. You've got to be kidding me. So we're going to go through some of them in more detail than others. But the first one is argument against EBM is about harm. You can't ethically do a randomized control trial if you know it would cause harm. And this was pointed out by a study done in MJ 2003. So that's 17 years ago, which is how long does it take for high quality, clinically relevant information to reach the patient's bedside? 17 years. I have a publication on that. So this was the parachute trial, and it was used to prevent death and major trauma related to gravitational challenges. They conducted a systematic review looking for randomized control trials, and they couldn't find any RCTs that demonstrated that a parachute could prevent orthopedic, head, and soft tissue injuries and mortality from gravitational challenges, i.e. voluntarily jumping out of a plane. So they did find some observational data. There was some data that showed parachutes could be used in an observational data setup, and people fell out of an airplane, jumped out of an airplane, had a parachute on, and they still got injured, and some people still died. There are also case reports of free fall where the parachute did not work at all. They free fell, and it wasn't 100% mortality. So we have case reports that some people could survive. So What's the value of a case report? It's so valuable, you won't see it. It's just one case. So Smith and Pell proposed taking all the EBM advocates up in a plane, randomizing them to a parachute or a sham, the backpack, and having them jump out of the plane. And when they landed, anybody who survived would be crossed over into the other arm of the trial. So if you were in the backpack group, you're going up again and getting a parachute. But if you were in the parachute group first, you're going back up again and jumping with a backpack. And then we would have solid evidence that a parachute prevents gravitational injuries and mortality. Now, obviously, this was a tongue firmly in the cheek sort of paper, but Hayes et al. In the CMAJ just 2 years ago published an article saying that most medical practices are not parachutes. And so people who keep saying, oh, we can't do research on that area, gravity is fairly well established. It's considered a law. Now, it's a descriptive law because physics is descriptive. We're describing the observed effect of falling at 9.8 meters per second. So it's descriptive, not prescriptive, but most of medicine isn't as solid as the law of gravity. However, there has been a study published 2 years ago on parachutes. They successfully conducted a randomized control trial. They approached 92 passengers on a plane. Their inclusion criteria was 18 years and older. They approached 92 people on a plane and said, would you jump out of a plane and you'll be randomized into a backpack or potentially the placebo group? Shockingly, 23 people agreed to participate in randomization. The composite outcome was death or major traumatic injury, and the result was parachutes did not reduce death or major injury. It was 0% in both groups with an impressive p-value of greater than 0.9. Now, the limits to this study was there was a difference between those who decided to participate and non-participants. Participants jumped out of the plane at an average height of 2 feet, traveling 0 miles an hour. In other words, the plane was on the ground, not moving. And those who said, nah, I'm not going to do this, were traveling at 500 miles an hour at an average height of 6 miles. Another argument to EBM is most published research findings are false. This is John Ioannidis. This is one of the most cited articles in PubMed. It was published 15 years ago in PLOS. And he said that when you look at research studies, most of their findings are false. It's a great paper. I suggest you read it. This guy has taken some heat lately over the COVID issue. I'm not going to go into that now. A third argument is about cookbooks, and I mentioned that already, but that just focuses on the literature. And I try to emphasize evidence-based medicine. The literature is only one, that blue circle of the Venn diagram. And remember, a cook can follow a recipe. Cooks follow recipes at times, but they still need to use their good judgment, right? And their clinical experience as a cook to make a great dish. And they also need to ask the patients what they value and they would prefer. Maybe some people want a little bit more paprika. Maybe some people want a little bit more salt, right? So it's not cookbook medicine. Evidence-based medicine is more than that. The fourth argument is evidence is often ignored. And this is just an opportunity for me to slide in some comments about lytics for acute ischemic stroke. Anybody who follows me on social media knows that there are 13 randomized control trials on lytics for acute ischemic stroke. 2 of them reported benefit. That was NINS and ECAS-3 out of the 13 for their primary outcome. So what did people do with the other 11 studies? They ignored it. Now, out of those 11, 3 were stopped due to harm, that was bleeding, and 1 was stopped due to futility. Now, both NINS, published in 1995, and ECAS-3, published in 2008, have both been reanalyzed, adjusting for baseline differences. In both instances, the placebo group had a higher NIHSS score. In other words, they had worse strokes at presentation compared to the TPA group, which had lower stroke scores or milder strokes at baseline. And we know that the severity of stroke at presentation is a strong predictor of outcome. And when NINS and ECAS-3 were reanalyzed, controlling for baseline differences, efficacy went away, but the potential harm remained. Yet we are still being told to get with the guidelines. And there are performance metrics to make sure that we're giving out TPA despite the evidence. And then the lack of time. And I love this slide. I picked this one very specifically because look at the faces of the doctors. Look at the doctor at the head of the bed and look at the doctor at the foot of the bed. Seriously, you want me to do evidence-based medicine? You want me to search the literature, critically appraise it, and ask patients in a shared decision-making model about their values and preferences? It's just not realistic. There's about 4,000 PubMed articles published every day. I don't have time to eat or pee on a shift. And many patients that I see have low health literacy. Seriously? Shared decision-making. You've got to be kidding me. But I can tell you with practice, doing critical appraisal, getting experiencing on searching for the best literature, gaining experience and learning how to communicate in a shared decision model with patients, you can provide patients with the best care based on the best evidence efficiently and importantly too, with high satisfaction scores. So basically, evidence-based medicine is the worst form of evidence except all the others that have been tried. Winston Churchill, paraphrasing. There are alternatives to evidence-based medicine. This was adapted by from Isaac and Fitzgerald that was published in BMJ in 1999. He had more than five alternatives to evidence-based medicine, but I've just picked 5 because, again, it is my favorite number. And of course, because I'm giving a talk on gender, here's the first one. Eminence-based medicine. This will be the senior white male colleague who places experience above evidence because experience is worth any amount of evidence. And these colleagues have a touching faith of clinical experience that has been defined as, quote, making the same mistakes confidently or with increased confidence, over an impressive number of years. And this eminent white physician usually has white, thinning hair with a balding patch, which is referred to as the halo effect. The other 4 that I wanted to mention, there's eloquence-based medicine. This is the physician that has the year-round tan from frequent big pharma trips to Hawaii, a silk tie, an Armani suit, and a tongue that is smooth as silk. There's veminance-based medicine, and that's where you substitute the quantity and often associated with the volume of evidence as an effective technique to browbeat your colleagues and convincing your friends and relatives of your impressive medical ability. Quality is usually more important than quantity of evidence. Now, the 4th one is nervous-based medicine, and that's very important in some jurisdictions. It's not such a big deal where I practice in Canada, but nervous-based medicine, this is the fear of litigation. So I recognize that this is going to be a very, very concerning issue. The fear of litigation is a powerful stimulus to over-investigate and over-treat. And in an atmosphere of litigation phobia, what's the only bad test? The one you didn't order. And then the 5th one is confidence-based medicine, but this is generally restricted to surgeons. All right, that's been a long walk to get to the gender inequity in the house of medicine. But I want to push you a little bit out of your comfort zone. Some people may get a little disturbed through this next section. And I understand we learn at the edges of our comfort zone. So what I'm going to use is the 3 pillars of evidence-based medicine. That's the literature, if you remember, in the blue circle, the clinician in the green circle, and the patients in the red circle, pointing out some serious problems with this EBM model, which I'm clearly an advocate for. I have a reference for each claim I make, and these will be available with the slides after the presentation. So, the medical literature, the blue circle of the Venn diagram. There are many examples of gender inequity in the medical literature. Females are less likely to get their research funding than men. They don't get as many grants. Women are less likely to rise to the top of academic positions at universities compared to men. Men are more likely to rise to the top of academic positions within medicine, not just within the university. And if you look at the academic positions in emergency medicine, again, it's men are more likely to have the top positions. Men are also more likely to be the first author on a medical publication. We talk about our specialty, emergency medicine. Men are more likely to be the first author on an emergency medicine publication. Sensing a theme here? And then finally, pediatric emergency medicine, where it is almost 2/3 female, 62% female, but the lead authors, 42% for pediatric emergency medicine papers. So there does seem to be a difference between men and women. Women are also excluded from being participants in medical research. This is the book from the Institute of Medicine, and it's a good resource in discussing the ethical and legal issues of including women in clinical studies, because women are often excluded in the medical research. And so where's the external validity? Sometimes it may not make a difference, I understand, but sometimes it can make a huge difference. The most egregious example I found when researching this subject about women being excluded from research was a study involving the association between various risk factors and uterine cancer. Women were excluded from the study.
What?
I thank you for someone who doesn't have their microphone on mute. I think I heard WTF, but yeah, really? They excluded women from a study on uterine cancer. Now I could stretch it to maybe, breast cancer, because men do get breast cancer, but uterine cancer, this was shocking. We need to ensure that women are getting equal access to grant money so they can ask the questions that are important to women and create the medical literature that informs the care of women. This will also lead to more women being first authors on a medical publication. We need to include rather than exclude women as participants in medical research. When I'm doing my SGEM, I usually identify the population, and then I talk about the exclusions, and often it'll say women who are pregnant or lactating or women who may be pregnant are excluded. And then we just extrapolate from male subjects. Let's look at the clinicians themselves. This will be the biggest component of it. This is the green circle of the Venn diagram. And there are many examples of gender inequity in the second pillar of evidence-based medicine. Men have historically been the physician in the room, while women have historically been mistaken for the nurse. I understand that on staff you have about a 50-50. I would love taking a poll and saying to the staff, of the men, how many times have you been mistaken in your entire career as the nurse? Response would be once. Once I was, oh, you must be the nurse. And ask the same question to the women who are on staff and say, how many times in your career have you been mistaken as the nurse? And I suspect the answer will be, you mean my whole career? How about per hour? It's incredible. And I know that you guys have big badges that say MD or DO on them. You have your name embroidered on a white lab coat. You even may have your name embroidered on Fig scrubs, although I don't know if you still do, but we'll get to that later, that says that you're a doctor, and yet you're still called out as the nurse. Or your patient satisfaction scores are, yeah, it was a pretty good visit to the emergency department, but I never saw the doctor. And then look at those numbers. 80% of the workforce identifies as female, 80%, yet they make up single digits in the higher end of CEOs, CMOs, department chairs, and division chief. Now, I know that I was introduced as Bill. My first name is William, but my parents thought I looked too much like my dad, and so my middle name was Ken, and my dad's name was Ken. So I actually do go by the name of Ken. And my wife's name is Barb, so it is Ken and Barbie. And when I told her I'd been asked to give this talk on gender equity, she immediately sent me this link. And it was, why do men make more money? And it's because men choose higher paying careers like doctors, engineers, lawyers, or CEOs, while women tend to choose lower paying careers like female doctors, female engineers, female lawyers, and female CEOs. Thanks, Barb. All right, let's dig into the pay difference, because now we can quantify it a bit. The gender differences in the House of Medicine. What's the evidence and what's the dollar amount for the claim that males get paid more than female physicians? Well, Male physicians, on average, in all of medicine, get about $20,000 a year per year more. Males also get about $17,000 more per year in academic medicine. And if you drill right down to it, and I covered this study recently on the SGEM, in academic emergency medicine, our field, males get paid on average $12,000 more per year. Or if you're from the female perspective, you get paid $12,000 less per year. A recent study that was published in JAMA last year showed that female surgeons make 24% less per hour than their male surgeons. Now, before there's a whole bunch of hand waving and go, but what about this? But what they adjusted for various factors, and the pay gap still persisted. You look at my jurisdiction, so I don't want to be pointing fingers at somebody else. If you look at my jurisdiction where I work, the Ontario province, the Ontario Medical Association released a report just recently called Understanding Gender Pay Gaps Among Ontario Physicians. And it documented that male physicians on average bill about 16% more than female physicians. And again, go to the document itself. I will have a link for you to look at, and you can go through all the various adjustments they did to try to control for confounding factors, and still found this gap. And this is similar to the 17% gender pay gap found in the United Kingdom for hospital doctors. So it's pretty consistent. Now, this is Dr. Michelle Cohen there on the left, and her co-author, Dr. Tara Kieran. And they wrote an article called Closing the Gender Pay Gap in Canada. And this was published just this year, Canadian Medical Association Journal, or CMAJ 2020. And it defines the problem of gender pay gap and tries to address some of the myths. I did an SGEM episode with Dr. Cohen earlier this month, and she answered 5 questions about the gender pay gap. The first one, is it real? And the answer is, it's all real. The second thing is, do women just work less, or they work less efficiently than men? And the answer to that is no. If you control for the various confounding variables, that is not the case. If you account for less hours or efficiencies in various factors, still persist this gender pay gap. Well, what are the root causes? The answer is it's complicated. What about other jurisdictions? Well, we find similar results of a gender pay gap. And I mentioned that study of about the $12,000 difference in academic emergency medicine. That was out of the US. The 17% gap is out of the UK. The 16% gap is out of my province. And so there is multiple countries that support, in other jurisdictions, there is this pay gap. And the fifth thing that probably people want to get to is what can be done about that? That would be a whole nother talk. And the easiest way to find out what can we do about this is listen to the SGEM podcast with Dr. Cohen. It's titled, and because I like to start all of my podcasts with 80s theme music, it's got a great ABBA song that starts this one. It's Money, Money, Money. It's a rich man's world. And you can listen to Dr. Cohen discuss some of the things that can be done about the gender pay gap. And don't forget about the patients. That's the red circle of the Venn diagram. This is the third pillar. And it also shows evidence of gender inequity in the House of Medicine. Women are more likely to access and utilize healthcare compared to men. Perhaps that's why they live longer. Mothers make up approximately 80% of healthcare decisions for their children. And, I've got a classic story about that, is that as an emergency physician, and I'm board certified in both emergency medicine and primary care, we had young children, and my wife would come to me and say, Ethan has this. And I would give some evidence-based medicine answer, and she'd go, are you sure? And so I'd say, well, talk to your father. He's a pediatrician with 30 plus years of experience. She'd call up her dad and go, are you sure? And then she'd talk to her mom. So moms make up about 80% of healthcare decisions for their children, even in households that have physicians that are male. Women are systematically undertreated for painful conditions. This was the big fifth vital sign oligoanalgesia research that came out in the early 2000s. Women are 7% less likely to get any analgesia compared to men for the same condition. And they are 10% less likely to get an opioid compared to a man. And we can have that nuanced discussion of whether they should get an opioid in the first place, but if they both have a fractured ankle, women, and I'm using fractured ankle as an example, women were 10% less likely to get opioids for painful conditions compared to men. Even for life-threatening illnesses, so let's not get into the whole opioid use disorder thing, even for life-threatening conditions, like an MI, women receive less treatment and have double the odds of dying. So we need to ensure everyone gets the emergency care they need, regardless of whether they identify as male or female. And I really like this image. This image summarizes emergency medicine for me, because emergency departments are the lighthouse in the house of medicine. It is a beacon. It is the one place, the only place I know of in the house of medicine that the light is always on, and because I know other places are always on, but it's always on, but it will treat anyone for anything at any time. And I like to add, hopefully without any judgment. And that summarizes emergency medicine for me. But I might have upset a few people, because gender inequity discussion does dichotomize things into male and female. And this is a false dichotomy. There are people who do not identify as male or as a female. It's non-binary for them. Gender is complex, and it's on a spectrum. It has layers. Ooh, who knows where that's from? There, I just made one up. So it has layers. Anybody know where that movie is from? Put that in the chat. There is, however, differences for how a person identifies, how they express themselves with regards to gender, their sex assigned at birth, who they are physically attracted to, and then there's who they're emotionally attracted to. So it really is complex. The gender unicorn is this graphic representation demonstrating the complexity of gender and sexuality. And we need to make sure that in the house of medicine, it's not just inclusive. We don't just tolerate people, but we accept them and we welcome them to everyone, regardless of how they identify. There are other inequities, though, in the house of medicine besides just gender. There are problems with race. There's problems with religion. I mentioned that I'm an atheist, and that raises some eyebrows from time to time. They are like, how can you have a moral code? How could you be such a nice person? How can you be such a caring person without a faith-based model? So there's religious issues, socioeconomic status, mental health. I've been quite open about my experience with burnout. How about physical abilities? There are lots of other inequities in medicine besides gender, but I was asked to speak about gender. So in order to provide patients with the best care, based on the best evidence, we need high quality, clinically relevant research that is inclusive and representative of everyone, removes inequities from those who generate the research and participate in research studies, and provide care at the bedside. And finally, recognize that everyone has value and it should expect and deserve great care. Well, I couldn't have picked a better week to talk about gender inequity in the House of Medicine, because this controversy exploded this week on social media. And this was about the company called Figs. And Figs is a clothing company. It was founded in Los Angeles, I think in 2013, by some women who are the leaders of this company. And apparently, I don't have any, but apparently they make some amazing scrubs that are wonderful, I guess. So great, super. Some people find that they're expensive, but that's a value judgment on what you put your money towards. But they came out with this ad. I think it was 2 days ago. It may have been 3 days ago, but they came out with this ad. and let's see if it works. And I just want to know if anybody sees any potential problem or problems with this ad. So let's see if it plays on this online medium. So does anybody need to see it again? Let's go through it. So we have a young, thin woman in pink scrubs, glasses on, holding a textbook upside down. All right, let's try that again. I'm not sure if I caught all that. All right, so it's a young woman, glasses. Oh, what's the book say? Medical Terminology for Dummies. Oh, she's a doctor. Oh, she's a DO. Really? And there she goes. So does anybody recognize that there could be some people who perceive this differently than perhaps it was intended? Now, since I can't see the chat, I'm hoping that the chat is exploding right now with comments about what could be potentially perceived as not great. I'm very Canadian, aren't I? All right, so let's look. Yes, holding up a textbook, it says Medical Terminology for Dummies. And then zooming in at that one part of that dancing video, showing a badge that says Doctor of Osteopathy. Well, this led to some great controversy on Twitter. And the first tweet I saw, and there were many, said, "We dropped the ball and we're very sorry. We love you guys, very meta, and we'll always listen to what you have to say." And that's what the tweet came out from Figs. People were asking for it to be taken down. I said, whoa, Figs, okay. And I went and found a Wikipedia page that day. And on that day, there was already an update to the Wikipedia page saying that the company had created some controversy, and the response that they had garnered further criticism as they were accused of issuing a non-apology, and that has led to a boycott of the brand. That was like within 24 hours. The power of social media and networking. I didn't try to jump on the whole sort of thing too much, but I wanted to know why this happened. What happened? What were they thinking? I mean, I am not perfect. I mean, seriously, I am not. I am so far away from. Ask my wife, Barb. I am not perfect. I make mistakes. I have made mistakes. I will make mistakes in the future. And some of my mistakes have been little, and some of my mistakes have been really bad. And it's not the mistakes that define who we are. What really defines who we are, in my opinion, is how we respond to the mistakes. How did we address the mistakes? 24 hours after the first apology came out a more formal apology from Figs, and I can put to that. But apparently there was also another image and video, but another image at least, of a man walking out in scrubs holding a book called Medical Terminology for Dummies. I can't get a zoom in on this picture because I couldn't find the video. It may have been taken down. But this is the badge that they're wearing apparently says RN. And so I don't know if this is a dig at nurses, a dig at nurses, the whole medical terminology upside down. I don't know in the marketing department, like what was the thought process? Yeah, have fun, come out reading a book upside down, and it's for dummies. Anyways, swing and a miss big time here. Kevin Clower, Dr. Clower, who I've worked with and I have a great deal of respect. He's an excellent educator, fantastic. Oh, he's a DO. I had no idea. I'm Canadian. I didn't know that there was this big distinction or some kind of historical distinction between DOs and MDs. I just worked with Dr. Clower, taught with Dr. Clower. He's a fantastic human being, and he's the head of the American Osteopathic Association recently. And so he sent a tweet back to Fig saying, remove your offensive ad, or they're going to proceed with a defamation lawsuit. Holy smokes. Well, Figs responded. They've got a longer, more thorough apology. No apology will satisfy everyone. And as part of that apology, Figs is committed to working with the AOA and going to give them $100,000 for the effort to address some of the issues that were raised because of this ad campaign. So very, very interesting, disturbing, concerning, don't know what the right word is for this situation. But again, I want to see how it all turns out. I want to see what the thought process was and how they address it. And we're early on into this. And so I'd like to see what's done. I think that will really define what happens with this company called Figs. My second last slide, it says from evidence-based medicine, which I gave like a 15-minute presentation because I'm a big fan of evidence-based medicine, having the evidence inform our care, guide our care, not dictate our care, use our clinical judgment, and engage with the patients asking about their values and preferences. But I gave you multiple citations, multiple lines of evidence that each of the three pillars is male dominated and has gender inequity. And so it is a progression to feminist-based medicine, recognizing that there are gender inequities. And the first thing is recognizing that it exists in all three pillars of evidence-based medicine. And those multiple examples include inequity in the literature, the clinicians, and with the patients. But this male-female dichotomy is a false dichotomy, like I mentioned. So I suggested that the next step would be gender-based medicine, more inclusive concept, no matter how you identify. I don't care how you identify. I mean, I care about you as a patient, but I don't care how you identify. I just accept. Then ultimately, though, to humanist-based medicine, because there's only one race, the human race, and acknowledging all diversity on this planet, that everyone deserves the best care based on the best evidence, no matter what. Thank you very much. And that's my from evidence-based medicine to humanist-based medicine, gender inequity in the House of Medicine presentation. My Twitter handle is down there on the right. It's at the SGEM, and the website address is there, thesgem.com. But I should tell you, I thought my email was on there. It's thesgem, go figure, thesgem@gmail.com. And I'm happy to answer any questions after this presentation. And I can